بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا أن هدانا الله. It is my great pleasure and honor to be invited from my role model, Dr. Saad Mahdi, in our first collaboration between MEGA is the big brother of MABIC. Really, it is extraordinary chance for me. Thank you, Dr. Saad. Today, we have an important issue to be discussed, which is our patient safety. Of course, patient safety and satisfaction are our aim in our daily practice. Let me welcome our great speaker today, Professor John Doyle. It's my great luck to have you today also and meet you, Professor John. Professor Dr. Magdi Khalil, my great professor in Manufia University and my role model. Professor Dr. Medhat Shalabi. I'm so delighted tonight because both moderators of this great session is my elegant and dear friends, both Professor Dr. Mu'taz Abdulrahman, the man of pediatric anesthesia, and Professor Dr. Yasser Rida, the man of regional and pain blocks. I'm so happy and delighted to introduce this webinar today. It will be a great point in my CV. Thank you for you all. The floor for my dear colleague, Mu'taz Abdulrahman, to introduce Professor Dr. John Doyle. The floor for you, Dr. Mu'taz.
Thank you, everybody, for attending this webinar. I'm sorry, I had a little bit of a blip with my computer, so I'm having to dial in from my phone for the time being. It's really good to see all the, I would say, the nice people who we know from before. It's worth saying something about Mega Online. I think they have actually produced quite a lot of decent learning material over the last few years. And I would have to be grateful to my friend and colleague, Professor Saad Mahdi, for being behind all this work. And we really, really appreciate your work. It's very sincere, and we do appreciate your commitment. Tonight, of course, we're going to talk about safety in anesthesia. And we're delighted to have Professor John Doyle, who has been really, really, again, helping the course of learning in anesthesiology for years and years. We've known him through his very informative and decent, nice lectures. He also helped a lot with Mega Online, and he's done quite a lot of lectures for Mega Online, and we're really very grateful for that, Professor Doyle. Professor Doyle is with the Department of General Anesthesiology in Cleveland Clinic, as well as the Professor of Anesthesiology at Cleveland Clinic, Lerner College of Medicine of Casey Western Reserve University. He received his MD degree in the 80s and his PhD degree in Biomedical Engineering as well in 86, both from the University of Toronto. And then he received his Canadian board certification in anesthesia in 1986 and his American certification in 1989. Professor Doyle has a long-standing interest in ENT anesthesia and difficult airway management. We all have seen his work in the difficult airway and attended his lectures on that, as well as an interest in the use of technology in medicine. His research has been supported by a number of funding agencies, and he holds positions on a number of editorial boards. Professor Doyle is the past president of both the Society of Airway Management and the Society for Technology in Anesthesia. He has received clinical teaching awards on 4 occasions. Professor Doyle, please share your screen.
Hello there. Can everybody see me? My slides okay? So let's get started. I want to thank everybody for an opportunity to talk on a subject that is very important and very interesting. It involves both clinical as well as technical aspects, as well as understanding what's going on as a human being in the realm of psychology. So the topic is the human factor in medical errors. And we'll take a look at a variety of approaches to dealing with this. First of all, I have no conflicts of interest. And also, if anybody wants a copy of these slides, write to me at djdoyle@hotmail.com, and I'd be glad to send a copy of your slides your way, which you may want to use for your own teaching, or simply because there may be articles that I refer to here that you may want to be able to look up in detail. And so getting a copy of the slides can be advantageous. Here's my outline. I want to talk about human error in life and in medicine, the right root causes for human error, the so-called Swiss cheese model, talk about human error in airway management as an example, and how there are efforts to reduce error. So that's the outline. Some objectives: to learn a bit about the nature of human error, understand the of punishment as a means to responding to human error. Some people think, well, we'll just punish everybody. That doesn't work that well. Apply these concepts to the field of anesthesiology and clinical medicine in general. So let's start off with some horror stories. Horror story number one, 3 mLs or 30 milligrams of rocuronium were given instead of 3 milligrams, giving as a defasciculating dose to an awake patient. So this happened to one of my colleagues. As soon as my colleagues saw that the resident had given the wrong amount, gave 3 milligrams, 3 mLs instead of 3 milligrams, immediately the propofol went in to make sure that the patient didn't experience anything adverse. So here an example: someone said 3 and they assumed 3 mLs instead of 3 milligrams. Horror story number 2, same kind of problem. 3 mLs or 300 units of insulin were given to treat hyperglycemia instead of 3 units. This happened in my hospital many years ago. The anesthesiologist recognized this error on the part of the resident and immediately started doing serial glucose levels and giving glucose, and because of that, no harm came to the patient. But you had to know that this was happening, and you had to do serial measurements and serial doses of glucose. Horror number 3, Canadian Journal of Anesthesia from about 22 years ago, about 18 years ago. Accidental administration of succinylcholine for the treatment of hypotension in the laboring parturient. So they gave a 10 milligram or 2 ml IV dose of what they thought was ephedrine was administered to the anesthesia resident. Apnea and loss of consciousness quickly followed. Code blue called. Mask ventilation performed until spontaneous breathing resumed, and there were no untoward sequelae. But there was a problem. This fridge was mislabeled, and it was succinylcholine mislabeled as ephedrine. So an example of another horror story. Here is another example. On the left, you have heparin, and on the right, you have hetastarch, in the days when we use hydroxyethyl starches in clinical practice. And here, the anesthesiologist was looking for another bag of hetastarch, and instead gave the bag of heparin, which contained 25,000 units of heparin. So another horror story. This one from the Institute for Safe Medical Practice. Fatal outcome after inadvertent injection of epinephrine intended for topical use. So in a day surgery ENT procedure, the surgeon requested wanted lidocaine 1% with epinephrine 1 in 100,000, handed a pre-drawn syringe, injected medication. Immediately afterwards, the patient experienced cardiac arrhythmia leading to cardiac arrest, and the patient died. So this was an overdose of epinephrine because it had been diluted incorrectly. So this is for topical use only. And you can see this drug error led to the death of the patient. Now, some of you may remember we had the Palm Pilot, which had a variety of tools available. Now we have them all on our smartphone. But this was from years ago, one of the first packages that were available to help the anesthesiologist on a Palm Pilot. Here was the Handbook of Clinical Anesthesia, 3rd edition, and it was available in a PDA version, which I purchased. And it worked for Palm operating system as well as the Windows CE operating system. This is a product I purchased some time ago. And here is the serial number for that. And when it comes to epinephrine, it says Bolus IV 2 to 8 milligrams dose to treat hypotension, 0.3 to 0.5 micrograms dose to treat cardiac arrest, continuous infusion 0.015 micrograms per kilogram per minute, use 1 milligram in 250 ml or 4 milligrams per ml. How many errors are present in this? And this was a published report. This is published software you could buy. How many errors? Well, it turns out there's 3 errors, both in the dose to treat hypotension, the dose to treat cardiac arrest, and the concentration of the drug as a continuous infusion. This is absolutely horrifying that this got through this level of quality management. Another example that comes from ordinary prescriptions that are written. What is this prescription for? It's not clear at all, but it turns out it's for morphine 10 milligrams IM. Who would have known? So a lot of people are requesting that when you write out prescriptions in longhand, that it be done in a clear font or done electronically. Nevertheless, there's recommendations about what symbols to use and what not symbols to use. This comes from the Institute for Safe Medical Practices, and this should be something that everybody is familiar with. Some things are abbreviations that should be used and some abbreviations that shouldn't be used. Here are some that are error prone. For example, rather than writing U, which is sometimes mistaken for 0, write unit. International units is discouraged. Write international unit in longhand because it's mistaken for IV. And these are examples of some of the kinds of things that should be avoided because they are error prone. This is becoming less common, hopefully, as computerization is taking place. But the introduction of computers into clinical practice adds its own new special problems. And I'll have an example to take a look at that in a little bit. Here's an interesting study called the July effect. And it identifies a spike in fatal medication errors when new residents arrive in July. They call this the July effect or the new residence hypothesis. And they found that what happens is that when the new residents come in July and they're getting used to the new system, there's an increased number of drug errors and deaths as a result of that. So 3 themes emerged during the course of that particular study. Fatal medications spiked in July and no other month. The July spike appeared only in counties containing teaching hospitals. And in these counties, July mortality from medication errors was 10% above the expected level. So this is an important point when residents come in July. So more objectives I'd like to talk about in this presentation: bad design, complexity, and software as contributors to human errors are things I would like to cover. It's worthwhile remembering that from antiquity, it's been repeatedly said that to err is part of being human. So Plutarch said to err is human. Shirley, 1635 in the book The Lady of Pleasure writes, I presume you're mortal and may err. Pope, essay on criticisms, to err is to human, to forgive divine. So here's an example of some of the challenges related to human error. All of these state that errors will be made by people despite their determination to avoid them. Yet people are consistently held accountable for their errors when they lead to accidents with adverse outcomes. Is this proper? Now, this particular author, Senders, argues that it is not the same way that in law, no one can be held accountable for acts of God, such as damage to a house after a thunderstorm and lightning. So this is his position, but it's a controversial one. What has happened is that these considerations have led to a systematic study of human errors. And one of the most important initial studies came from Massachusetts, from Jeffrey Cooper's laboratory, Preventable Human Mishaps, a study of human errors carried out in 1978 and published in Anaesthesiology. They found that the preventable errors involved human error 82% of the time, with breathing circuit disconnects, inadvertent changes to gas flow, and drug syringe errors being frequent problems. Overt equipment failures constitute only 14% of the total number of preventable incidents, but equipment design was indictable in many categories of human error, as were inadequate experience and insufficient familiarity with equipment or the specific surgical procedure. So he has spent his whole career looking at opportunities to improve patient safety in the anesthesia realm, and he shows up in the literature repeatedly. What we now know is that it's convenient to look at human error in a variety of categories. Diagnostic processes such as failure to employ the indicated test, misreading lab results, or failure to act on the results of monitoring or testing. Treatment errors, like an error in preparation of the treatment, of the dosage, delayed equipment, delayed treatment or appropriate care. So it can be a problem with treatment. Preventive failure to provide prophylactic treatment, inadequate monitoring, inadequate follow-up, and other things like equipment failure or things that are specific to an OR and ICU. So this is one classification that's been offered. Here's a little cartoon. The doctor says to Dilbert, "It seems we had a mix-up with your test results." Dilbert says that I'm not dying. The doctor says, "We doctors are amazingly smart, but occasionally make a little error. By the way, your pap smear was normal." "Yes, I understand," says Dilbert. So these are the kinds of errors that doctors can make, especially if they don't know their patients well. Now, a central theme to error is Reason's Swiss cheese model. Dr. Reason wrote a book called Normal Accidents, where he takes a look at the kinds of accidents that happen. And he says, when the holes in defenses due to latent conditions and active failures line up, errors will inevitably occur. So here we have the Swiss cheese with all the holes. Some holes are due to active failures. Some holes are due to latent conditions. And when they line up, you have accidents. He looked at 4 levels of failure: organizational influences, unsafe supervision, preconditions for unsafe acts, and the unsafe acts themselves. The first 3 are called latent failures, and the latter an active failure. So this is his model, which is used to this very day and explains a lot of the potential for errors that occur in the operating room and elsewhere. So for example, we might have an adverse drug reaction as indicated in the left-hand side, left upper. We might have a problem with drug A and drug B interacting. We have a problem that the subscriber doesn't know about it, that the computer screening failed, that the pharmacist's knowledge failed to recognize it, that there was a pharmacogenetic aspect to it, that the patient education aspect to it, and it results in an adverse drug reaction. On the bottom, we show that poor communication, poor policies, failure of teamwork can all result in an orthopedic surgeon failing to examine the ankle and the wrong ankle being operated on, or the ankle being okay and the patient anesthetized for unnecessary surgery. So these examples of failures that occur on the right, showing about adult respiratory distress syndrome occurring as a consequence of a number of things: transfer guidelines between hospitals, lack of supervision of the residents, inadequate training, improper ventilation technique, and so on. So in airway management, let's consider some examples of this categorization. For a diagnostic process, it could be failure to recognize esophageal intubation. For treatment, delayed reintubation in the intensive care unit. Preventive, inadequate monitoring of respiration, inadequate follow-up of a patient after extubation, or other, failure to communicate about a difficult airway by not writing a note in the chart. And in some hospitals, they have a difficult airway bracelet that they put on the patient as well. So about 40 years ago, Swain and Gutman came up with a categorization for human errors: errors of omission, like typographical errors; errors of commission, like hitting your thumb with a hammer; extraneous acts, reading the wrong report; sequential errors, lighting a fire before opening the damper in a fireplace; and timing errors, running a red light when driving. So these are examples of some of the categories. How do these categories apply to clinical work, such as airway management? Well, an error of omission might be forgetting to inflate the endotracheal tube cuff. Error of commission, breaking a tooth while intubating. Extraneous act, drawing up drugs not needed. Sequential error, giving drugs before checking your equipment. And timing error, intubating too early when relaxation is suboptimal. So just an example that this approach by Swain and Gutman can be useful to the clinical world. Here are some examples of airway errors that fit into this category. Incorrect technique, where a supraglottic airway, such as a laryngeal mask airway, is put in where an endotracheal tube is needed, such as a patient with small bowel obstruction. Esophageal intubation. Intubation through the incorrect route, like intubating orally instead of nasally for certain kinds of oral surgery. Intubation using the incorrect tube, using a ray tube instead of reinforced endotracheal tube in some settings. Endobronchial intubation, where only one lung is being ventilated. The wrong cuff pressure, where too low, you get a leak; too high, you get damage to the tracheal mucosa. and incorrect precautions against aspiration, such as not doing a rapid sequence induction in a patient with a full stomach. What are the causes of human error in airway management? It can be poor planning, poor arrangement of the workspace, no testing of equipment before the procedure, a lack of knowledge, no knowledge of the ASA difficult airway algorithm and the various ones that have come out of the United Kingdom and Europe, poor judgment, limited experience, pride or hubris, denial that there's a problem, failure to arrange for help before the trouble starts, and failure to call for help when the trouble starts. These examples of human error in airway management. So let's take a look at these concepts in terms of their implications for anesthesiology, in terms of workspace organization, labeling of syringes, checking ampules, other things that are important, but we don't have time to cover in a lot of detail, our production pressure, getting through your list, getting your first time start on time, and finally, avoiding sleep deprivation. So let's take a look at machine, equipment, and workspace organization. Clearly, how this workspace is organized is very important in helping ensure safe outcomes. One of these things is drug and syringe labeling, and the International Organization for Standardization, ISO, has information about this that you can get at the websites shown here. So there are standards for this, both from the ISMP as well as ISO, as well as the American Food and Drug Administration and elsewhere. Here is an editorial, this one from 2004, from Beverly Orser, who's a professor and chair at the University of Toronto. They have an editorial, anesthesia-related medication errors, time to take action. So this is bearing on 18 years ago. What did they recommend? Well, they said the anesthesiologist should be aware of the risks of drug errors, ensure that checking errors are in place. Lighting should be appropriate. Drug storage arrangement should be consistent in all anesthetic care delivery units, so that where drug is in one place is similarly found in another place. You don't have to go hunting in a strange place when you're in an unusual operating room. Ampules should be read and reread before drugs are drawn into a syringe. Errors are unlikely to be detected once the syringe is prepared. Drugs prepared by the person who will administer it where possible, and immediately before use where possible. Syringes should be labeled with the name and concentration. Some places require the date if it's going to be stored for a while. Syringes intended for an emergency should be stored away from the immediate work area. And that's examples of atropine, epinephrine, ephedrine, phenylephrine. The international color-coded syringe labeling system should be used. Consider using pre-filled syringes for emergency drugs. Pharmacists should regularly visit the operating room to ensure safe drug use. And when drug manufacturers' packaging and formulation changes, anesthesiologists should be alerted so that they're aware that there's a change in the packaging for the drug. One of the things that can be a problem is bad design, as you can see from this teapot here. Bad design in anesthesia can be a problem. We can have problems with drug labeling, workspace layout, anesthesia machine flaws, and even patient-controlled anesthesia machines that unfortunately have killed patients by virtue of their design. So technology issues, the complexity of the user interface for the anesthesia machine and the electronic record can add a cognitive load to the clinician that directs him and her away from the patient towards filling in details on the anesthetic chart and in the machine that can be dangerous. A number of failure modes with increased equipment may increase as technology gets more complex. This can be frustrating to the clinician, and it may direct the focus away from the patient, called fixation error. Let's take a look at some drug label problems, for example. Here you can see when you have a drug like heparin added to the bag, you have to be very careful that you do not think that this is stored where the regular saline is stored, and you can easily give the patient a large dose of heparin. Sometimes it's useful to have attachments to all the ampules and vials, such as that shown here, and some hospitals do that right with a barcode so that you can scan it into the system. And this is popular in some places, but not implemented everywhere. What about the workspace layout? Here is an example where one of my residents laid out everything in such a really nice way that I asked if it would be okay if I took a picture of this because this is an example of how things could be nicely done with everything labeled. And so on the upper right, you can see our resident from many years ago. I was very proud of him doing such a fine job. What about anesthesia machine design flaws? Well, here's an editorial I wrote, Special Challenges with New Digital Anesthesia Machines. This is from 21 years ago. And here's one of the things I said. Some digital anesthesia machines use virtual instead of real gas flow meters. Instead of real gas flow meters that can be seen and controlled, the unit uses simulated flow meters on a video display. Some clinicians are concerned that virtual flow meters may not have the impact of real flow meters in attracting the notice of anesthesiologists. For example, some anesthesiologists do not notice that the oxygen flow is set to 0 at the end of the checkout procedure in the Datex Omeda ADU machine, which uses a virtual meter arrangement. Now, this flaw of 0 flow at the end of checkout has been repaired in some software upgrades, depending on what you get, but clearly you don't want no flow at the beginning of the checkout in case there's an emergency. So here is an example showing on the top the real flow meters and on the bottom the virtual flow meters that are on display. They're not real, and you have to make sure that they're not set to 0. Now, I wrote that editorial, and a guy wrote in from British Columbia, Canada, who said, although medical equipment manufacturers are slowly coping with the special challenges introduced when computers are embedded into medical products, it's apparent that not all manufacturers are committed to safe ergonomic human factors evaluation of their products. The ideal anesthesia machine should be intuitive and error tolerant, should also contribute to improved situational awareness. At the moment, such systems are largely lacking. Here's an example. This was from my friend, Dr. Oyston in Canada. And he said, here is the pulse oximeter cable that hooks up to the anesthesia machine he was working with. And it's not clear whether the cable went as shown this way or this way. It turns out the second way is incorrect and the first way is correct. But you don't want that to be so complicated that when starting your case, you would easily make this error. Here's another example. This is the Aspire ventilator that terminates automatic ventilation as a result of sustained airway pressure within the breathing system. And so the patient's not ventilated at all. And for the most part, these errors go to the notice of regulatory authorities, such as the Food and Drug Administration, and then these errors are corrected with software upgrades. Here's an example of one that actually killed patients. We're familiar with patient-controlled analgesia, where you push the button to self-administer doses, typically morphine 1 milligram at a time, with a lockout to typically 6 milligrams, 6 minutes rather. But there's been problems with PCA devices. For example, excessive sedation and respiratory depression with PCA often lowers patients' oxygen levels to unacceptable levels. If they get too much, you get respiratory depression. Many of these problems may be due to a programming error resulting from a hospital user interface, and some have resulted in human mortality. So while the patient interface is simple, it still can be confusing. Some patients confuse the PCA button with the nurse call button and give themselves an inadvertent extra dose of morphine when they actually intend to ask the nurse for help getting out of bed. Since most designs do not provide an indicator of the patient lockout status, such as a red-green light that would indicate whether you're getting or not, these demands are often ignored during a lockout period. And some patients just give up, finding the technology to be unsatisfactory, particularly in the perioperative period. Here is a patient who wrote to me when I had published an editorial on this. I thought you'd be interested in my pain pump experience I had at Tallahassee Memorial. I hasten to add that any hospital could have been at fault during my pre-op. No explanation was given about the pain pump. I went into surgery for removal of my uterus and ovaries, recovered, returned to my room, all pain-free. Gradually, the morphine wore off. My pain became real. The effects of the anesthetic had not worn off. I was quite muddle-headed. You just pushed the button for pain relief made no sense to me, and I could not properly be assimilated by my muddled brain. For well over 5 hours, I suffered while my husband stood by helpless as his efforts to get the hospital to give me something IM or IV, other than the push choice wasn't allowed. He wasn't allowed to punch that button for me. So this poor patient was very confused. they say, additionally, a lighted monitor, 4-inch large letters for the nearsighted police indicating when the next dose is programmed to be available should be mandatory. So all our suggestions are good, especially this idea of when you're available for the next drug, but they have not been implemented in any PCA machine I'm familiar with. Now, another interface is not that of the patient, but that of the nurse. And that interface can be complex. Nurses must correctly enter the drug concentration, the dose, lockup period, and other information for the unit to operate correctly. Unfortunately, medical instruments frequently have poorly designed user interfaces that promote human error, sometimes with life-threatening consequences, and so it is with PCA machines where patients have died. So this is an example of what's happening. The Abbott LifeCare 4100+2 typically hangs from a bedside pole, and to unlock the pump, you use a key. A plastic drug syringe is snapped into place into a motorized arm, and when the door closes, the pump calculates and displays how much drug is delivered. So Lin et al. Studied the nurse interface on the Abbott LifeCare system using cognitive task analysis. Based on this analysis, the interface was then redesigned to include a dialogue structure with fewer steps, a dialogue overview showing the user's location in the programming sequence, better command feedback, easier error recovery, and clear labels and messages. The study of the new interface showed significantly faster programming times, lower mental workload, and fewer errors compared to the manufacturer's original interface. So using human factors science, you can redesign these things so that they are less likely to result in errors. So there's a need for human factor studies in this equipment. They're obviously needed to ensure safe operation of complex medical equipment. Regrettably, such human factor studies on medical equipment are often abandoned in favor of early market penetration. So here's drug overdoses associated with this model. In 2 of these cases, the alleged deaths, the reasons for the death are the same. In the mode of operation used when nurses programmed the drug concentration, the unit displayed showed a particular concentration, such as 0.1 milligrams per ml. Nurses can either accept this initially displayed value or they can modify it using arrow controls. The safety critical flaw in the design is that the LifeCare 4100 model I've been showing you offers the minimum drug concentration as initial choice instead of the maximum drug concentration as initial choice. And so if nurses mistakenly accept the initially displayed minimum value, such as 0.1 milligrams per ml, instead of changing it to the correct value, such as 2 milligrams per ml, then the machine will think that the drug is less concentrated than it really is, and as a result, it'll deliver more liquid and thus more narcotic into the patient and deliver an overdose. So the Institute for Safe Medical Practice has recommended against purchasing Abbott's PCA machine, but now Abbott has come up with a safer model based on ergonomic principles. To close, I'd like to bring to your attention 2 of the seminal articles that led to the human error management movement. These are 30 years old, roughly. Human Error in Medicine by Lawrence Erlbaum Associates, and Error in Medicine from the Journal of the American Medical Association. So these are resources that you may want to start with, and there's been many countless review articles published in the meantime that I'd like to bring to your attention as you go through. So human error is the result of cognitive science, systems analysis, and human factors. It's very complicated, but using human error principles can result in safer outcomes for your patient. So I look forward to any questions that come by in the meantime. Thank you very much for your time, and I look forward to the ongoing future presentations. Thank you so much.
Thank you, Professor Doyle. That is an excellent presentation. I think I have put, I'm afraid the chat was off for some time. I asked the attendees to post questions on the Q&A, and I didn't realize that it was actually off. So we're happy to take any questions, please. If you want to type your questions on the Q&A section, that'd be really helpful. And meanwhile, I've got a...
Sir, I am Dr. Simanja. I'm just telling you from India, just one recent story of this drug labeling error. What happened, one patient, she came after cesarean section, basically, probably what we guessed, Tanaxa was given instead of Sensorcan. Both the vials are tranexamic acid and the sensor cane, the bupivacaine. Probably for spinal anesthesia, she was injected tranexamic acid, probably what we guessed. And after that, she had a cardiac arrest. She had a refractory seizure. She was intubated, ventilated, and was shifted to our hospital, our tertiary care hospital. We tried our level best. We did everything, but we couldn't save the patient doing everything. Then later on, we came to know such incidents are happening. Tranexamic acid was injected instead of bupivacaine. So we have to be very, very careful while giving and labeling drugs. Thank you, sir, for such an excellent presentation.
Oh, thank you. That was a good anecdote you provided. Good story.
That's good. Thank you for the comment. Please, if you have any questions, post them on the Q&A. I do have a question, John, if you don't mind me asking it. We recently actually installed an APR system, the EPIC system, and I'm not sure, obviously, because we just, I sat to configure it for the last 18 months, and I can't actually comment enough if it's going to reduce errors, and hopefully this is the thing. And I was wondering, what do you think about electronic patient records and electronic charting and using all these kind of scanners to scan patients, medications, and blood? Do you think that can mitigate errors?
So this is a good question, and it's one that is the subject of ongoing debate, particularly at places like the Society for Technology and Anesthesia, because all of this technology carries with it a cognitive load, as well as increased costs, increased complexity, and more opportunities for error.
Can I?
Nevertheless, they're worthwhile. They're still worthwhile.
Please, if you have a question, can you raise your hand and I will actually.
Sorry.
Yeah. Sorry.
Yeah.
Carry on, Professor. Yes, sorry. Yeah.
Remember that the systems such as EPIC are relatively new on the field, and there's a likelihood that as human factor science continues, many of the problems that are identified with the existing generation will be fixed, and it'll get better and better with time. So I'm optimistic, but people who think that there's no downside to it are fooling themselves. And the downside is that the increased complexity requires special training, for example. In the United States, you can find advertisements for doctors where they say, we don't use EPIC or any other EMR so that you can use paper records. And that means that you can get on board that day rather than having to spend a week learning to use EPIC. So the cognitive load is one of the biggest issues.
Thank you. I will take Professor Medhat Chalabi. I think you've got a question.
Yeah, it's not a question. I just wanted to say that my subject is going to cover this area where you are asking now, the technology, the new technology. So I would urge you to wait till I talk, because
actually, Medhat, thank you very much for this. I think this question actually spans over the 3 lectures. So we need every, we will canvass the opinion. I should have said that in the beginning. We would like to canvass the opinion of all the 3 speakers tonight about the electronic patient record, because it's an important thing. And obviously, if you have a good chunk about it, that'd be really helpful. And we'll let you talk about it. No problems. But it actually spans on all the safety. The other question for Professor Doyle, John, if you don't mind again, I kind of feel that mitigating human errors is kind of a cumbersome process. It's time consuming. And if we really want to do it appropriately, I think we might actually be kind of not efficient the way we want. What do you think about that?
I think a lot of it has to do with the design of the user interface. If the user interface for equipment is designed well, everybody wins. But as we saw with the PCA machine, the first generation PCA machine that we studied, it led to a number of deaths. But it was possible to redesign the user interface, study it on a bunch of recovery room nurses, and to show that you had reduced error rates under those circumstances. So in terms of the user interface design, it's critical, but it's going to require dedication on the part of the medical community and particularly the equipment design community to implement those principles and spend the time to do the human factors testing, which is expensive.
Fair enough. Dr. Muhammad Ahmed has got a question, I think, or raise his hand. Yeah.
Thank you, Dr. John, for this great presentation. As we all know, we have to learn from the medical errors, and in order to get the lessons, we have to report these errors. Most of us, when they face a medical error, they do not report because they are worried about the corrective action that has to be taken from the administration. And although most of our institutes encourage the just environment, that the error is mostly due to, it is a system error, not a personal error. But most of us do not report this error because of the fear from the corrective action. I want to ask, what are the medical errors, human errors, that are that will lead to a corrective action, and what are the other errors that will be directed to correction of the system itself, not correction or corrective action or punishment of the doctor or physician who did this error? Thank you.
That's a very good question. And here's an example. A doctor makes an error at the 17th hour of operating because he's very, very tired. And he wouldn't have made that error if he was awake, but he's been working steady for 17 hours. That is a problem with the system in the sense that he's forced to work such long hours that human error is inevitable. And in the aerospace industry and in the trucking industry and transportation industry, you are only allowed to work for a certain period of time. In aviation, no more than 14 hours, for example. So this is where the system needs to be fixed, but that may require hiring more doctors, and the hospital may not have the money for more doctors. And so it may say, too bad, and blame the doctor rather than blame the system. So the system has its own special requirements. It may not have the funding it needs to do a good job, for example.
Thank you very much.